Good morning, good morning.
Good morning, dear colleagues, dear attendees. It's a big pleasure for me to welcome you to the ISICEM number 43 here in Brussels. Well, it's perfect. We have no slides to start with. Okay, now it's much better. So we have a very full scheduled meeting, so I had to be very short. Let's say I'm not going to intubate you with a very long speech, but I hope that this meeting will resuscitate the knowledge, your skills with the latest breakthrough in our beloved discipline, critical care medicine. It's been a very hard work to bring, again, here in Brussels, so many people, so many experts worldwide. And we really hope that we will share a very great experience all together. So, as I'm a little bit opening, like, a very young rock band opened before Rolling Stones. I asked ChatGPT to help me to say something a little bit original to start with. So I asked whether ISICEM is a good meeting. And it seems yes, it's a reputable and valuable meeting for professionals with a very long history of attracting distinguished speakers. So let's say it's a good meeting to be here. And why should I attend ISICEM? Because you can exchange knowledge. You can, of course, have network opportunities, professional development, continuing education, and of course, you can present your work. Don't forget, poster presentation for all our rising stars. Now, to finish with some artistic issue, I asked whether ChatGPT can write a short sonnet to invite people to attend ISICEM, and this is the results. In Brussels' heart, where knowledge seeks to thrive, a gathering of mind and medicine, ISICEM awaits, where we shall dive into the depths of healing discipline. Intensive care and urgency we share, exchanging thoughts with peers from distant lands. In lecture halls, united minds prepare to face the future ever-changing demands. Embrace the chance to learn, connect and grow with expert guiding through the latest trends, a vital chance for seeds of change to sow, and find the means to reaching life-saving ends. So join us at this vital rendezvous where wisdom, hope, and healing shall ensue. It took me 50 minutes to fully understand what you were saying, but I think it's a nice way also to welcome you and hope that you will enjoy the meeting. And now, of course, it's time to leave the scene to the big boss, to the chair of the ISICEM meeting, Professor Jean-Louis Vincent.
You can stay if you like. Huh? Thank you very, very much indeed, Fabio. Now you are the boss. I am not the boss any longer. I am doing my best to help. And indeed, it's a pleasure to see you all here. We would like to warmly welcome you. Our schedule is very tight, as we heard. We have many new things to present during this opening session. So that I will not go and discuss and show you where the rooms are. Many of you know the place quite well now. For those who have not been with us before, I'd like to remind you that it may be sometimes a little difficult to reach rooms in the upper floors, but you have the app that will definitely help. Something new this year, there is water! Water everywhere! I didn't say beer, I said water. So people were complaining they couldn't find water elsewhere than in lavatories, so now it's done. Scientific meetings move more towards practical sessions. Of course, we still have many standard presentations, but we have more clinical challenges, sessions, demonstrations, etc. And there may be still some room for some demonstrations like trauma management or other sessions. And I would like at this stage to thank the scientific advisors for their excellent advices throughout the preparation of this meeting. Now, this is the slide I showed the last year, saying, okay, now we are slowly recovering from COVID, and I said the projection for 2023 may be somewhere there. We are not exactly there. We will not reach the 5,000 participants, but we will be over 4,500. So we think it's a linear progression, and it's quite reassuring to see that indeed the numbers grow again. The sponsors are of course essential, and we would like to deeply thank them, especially the platinum sponsors, AOP, Baxter, CSL Behring, Cytosorbents, Hamilton Medical, and also all the gold sponsors. Please check with them, silver sponsors as well. Go to the scientific exhibition where you can not only find your bag, but also have some refreshments and some good things. I'd like to thank our team, small team, for such a meeting, but they do a great job under the leadership of our manager, Veronique de Vlaming, always very professional and taking care of everything very, very efficiently. So we are very lucky to have these people with us. Don't hesitate to tell the world what you learn, what you like, or no, not what you dislike, only what you like. And if you like, there is a free Wi-Fi, you can easily connect. That's not an issue. Now, don't forget our future meetings. The meeting that was very successful this year, a few months ago, on preclinical research in acute cardiac and critical care. Don't forget the echocardiography course. We had one yesterday, but there is another one in November, with direct transmission of images from our department to the conference room at the Erasmus Hospital. Don't forget the Euroneuro in November in Brussels this time. It's a meeting that moves, but it will be in Brussels next November. And of course, our Rome meeting. And this time, the topic will be cardiogenic shock. So mid-December, come to Rome. It's a very interactive meeting with lots of discussions. Okay, of course we will have a look back to COVID, perhaps even with still some studies on new therapies, but essentially with the lessons to take. And we will see what we have done well and what we could do better, and how we could keep our staff happy, etc. But since Fabio touched on AI, I'd like to share just a few slides with you, because I think we will discuss a lot some elements related to the future. It's amazing to think at what this meeting will look like in 5 years or in 3 years from now, where we will see how AI, that we call now augmented intelligence. People have some difficulties with the word artificial, but we will see how this helps to make progress from protocolized care in all cases, not only in particular diseases, to personalized care, as that's what we need the most in our very complex critically ill patients having a number of problems. If we take just sepsis, we need to individualize the antibiotic therapy. We cannot go without it. We need to individualize the need for source control. The same thing is true for IV fluids. We cannot go by formula. We need to individualize this therapy. Vasoactive agents, the like. It's not just blood pressure at 65. Management of shock is much more complex than just restoring a number for a mean arterial pressure. Hydrocortisone, and we will see some exciting news this morning about hydrocortisone in severe pneumonia. Vasopressin, maybe we should give it very early. We need to individualize all these elements. And in the respiratory field, it's the same. This very recent paper shows how we can improve respirator management by a combination of discussions, teaching, seminars, etc. But there are also several variables that we need to integrate. And it's not so easy. The management of ARDS is not just maintaining a low tidal volume and a limited driving pressure, and just the PEEP level were more or less between 5 and 15. It's much more complex than that. So we have also there a number of options that AI could really help us to choose from. And this is just one of these examples showing how a business intelligence system could help to limit the possible lung damage with our mechanical ventilation. And very interestingly, I think we will more than ever combine the effect of our interventions on different organ systems. And in particular, when we go to respiratory sessions, we speak only about the lungs, perhaps not enough about the effect on right ventricular function. This paper will come out soon, integrating ARDS with right ventricular dysfunction. So that's another dimension. It's becoming complex to put everything together. And that's what our very good friend Paolo Pelosi wrote recently, all these different aspects that needs to be integrated. In the future, we'll have automated measurements of VTI. We will have the probes on the patient's chest. We will continuously monitor these patients. We will have ultrasound just fixed on the skin, allowing us to monitor our patients non-invasively, continuously, and even to look at the effects of fluid challenge non-invasively with these systems. Of course, we already have the closed-loop systems with Dr. Jostin and others. We worked on this, but again, it's not just controlling the blood pressure that counts. In anesthesia now, there are some systems integrating variables, predicting catastrophes, and helping to manage the patients optimally. And this is very exciting, and I think we will learn from anesthesia as well and bring it to our intensive care units. Well, as I said, the time is very limited. We will discuss all of this in all our sessions, but we are living very exciting times, not only looking back at COVID, but also looking at the present, of course, and the next future with the development associated with AI in the intensive care unit. So have a great meeting. Enjoy it. And we will now leave the floor to our chairpersons. Welcome.
Dr. Ellie Azoulay, and we have the privilege of moderating this session.
Please press the button icon on the microphone.
Oh, sorry. I apologize. I'm Haley Gershengorn. This is Ellie Azoulay, and we have the privilege of moderating this first session. Our first couple of speakers to present to us on a report of the Roundtable Conference, ICU Populations from Syndromes to Phenotypes, are Carolyn Calfee from the University of California in San Francisco, and Anthony Gordon from Imperial College London. Thank you.
Thank you so much, Dr. Gershengorn. On behalf of myself and Dr. Gordon, it's really a pleasure to be with you to present the results of the Brussels Roundtable Conference that we held over the past 3 days here in Brussels. I'd like to start by thanking Jean-Louis and Fabio for the opportunity to chair this exciting meeting and to present to you all today. So this is an image of our roundtable participants on the top of the Warwick Hotel where the meeting was held. We had an amazing list of fantastic speakers from around the globe, from lots of different perspectives, and I really want to thank all of them because their participation and engagement was really what made the roundtable an exciting and dynamic event to participate in. I want to particularly highlight our Rising Stars. So this was a new program that we had this year where we invited Roundtable faculty to nominate Rising Stars to help us both to nurture the next generation of investigators in the field and to make sure that we're adequately representing the diversity of perspectives that are important for a topic like the one that we're going to be covering. And they all really made fantastic contributions. All right, so what was the focus of the roundtable? Well, it was on this idea of precision or personalized medicine. What does that mean? Well, we've all heard the phrase, right drug, right patient, right time. And I think we can call it an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. That's kind of a generic definition of precision medicine. What does it mean really in the context of the ICU? Well, it's thinking about when and how and whether we should move from thinking about the syndromes that we treat as syndromes like ARDS and sepsis, and perhaps move towards thinking about phenotypes. Why would we do this? Because we want to quantify both the obvious and clinically apparent, as well as the latent or hidden heterogeneity of critical illness to develop better treatments and ultimately to improve patient outcomes. And we took this phrase from a nice review that was written by Kim DeMerle in Critical Care Medicine in 2021, where she said, well, all we want is clinically relevant, non-synonymous, biologically plausible, treatment responsive, reproducible, and easily determined subgroups. So a tall order, but that's what we're focusing on looking for. There are numerous examples in ARDS and sepsis. Latent classes, for example, in ARDS, which have been termed hypo and hyperinflammatory. A number of different approaches to profiling gene expression in the peripheral blood in sepsis, SRS1 and 2, Mars 1, 2, 3, and 4, inflammopathic, adaptive, and coagulopathic. Clinical classifier systems that use clinical data only that Chris Seymour and colleagues developed in sepsis. Physiological phenotypes that Ewan Gallagher and colleagues have described in ARDS focused on elastance. There are some really interesting examples from traumatic brain injury where they've actually really developed a nice framework for thinking about biomarkers that can help them understand severity, progression, and response to intervention. And using that approach, they've developed multi-omic endotypes of TBI that not just have different probabilities of survival, but seem to respond differently to treatment. Acute kidney injury is very heterogeneous as well, both in terms of its underlying risk factors and in terms of its pathophysiological mechanisms, yet all of these types of AKI are diagnosed via creatinine. We thought about pediatric critical care where there's additional heterogeneity introduced by developmental differences in the immune response as you move from infancy through adulthood. There's heterogeneity in the pathogens that cause these syndromes. Viruses, bacteria, and fungi may all contribute to these organ failures. What aspects of the host response are shared and what aspects are pathogen specific? Many cases of sepsis are culture negative, and perhaps molecular diagnostics will help us to understand this heterogeneity even better. All right, I'm going to hand over to Dr. Gordon for the rest of the slides.
Thank you, Carolyn. So understanding these subphenotypes is all very interesting, but if it's going to have clinical utility, it needs to affect our treatment choices. And there is evidence that it's doing that. This is from the HARP2 trial, looking at the latent class clusters, hypo and hyperinflammatory. Where in the overall population, there's no significant benefit from simvastatin, but it looks like there really is a treatment effect, mortality benefit in the hyper-inflamed group, but not in the hypo. We see similar examples in the VANISH trial, according to the gene expression profiles when patients were randomized to steroids or placebo. Over on the right-hand side, you can see the SRS2 group, which have been shown in multiple cohorts to normally do very well in sepsis, actually seemed to be harmed when they were randomized to get corticosteroids. Does this explain some of our disparate results in steroid trials? Maybe there is some benefit, but in other populations, we've not seen that because some of the patients are being harmed. We need to understand that. So if we're going to take that forward, though, how do we do it? Well, we're going to need to understand the biological mechanisms. What are the molecular drivers of this? And so we would suggest that what we need to do that is have solid preclinical models that identify the pathways and the targets, that we then develop multiple cohorts with that rich clinical data, but that includes imaging and molecular data now. To bring this to the bedside, we need, though, rapid diagnostics and the data science to accompany it. That information, that technology is out there. There are now point-of-care devices that are being used in many intensive care units around the world, and we can incorporate those into our clinical trial designs. We will need to change the paradigm of under which we do our RCTs, But again, we're familiar with some of these more novel techniques that we will need to use. But it's not just all moving forward. We will learn while we do our trials. If we collect the right information, we have this backwards translation. We will understand more about the mechanisms, develop further treatments if we go down this path. We discussed many ways that may happen, but things like including mediation analysis in our RCTs. If we can understand the effect a treatment is having on potential mediators that affect the outcome, we will learn about those pathways rather than simply collecting the treatment and survival at the end of it. Do we understand that mechanism? And we will again learn how our treatments are having those effects. We all agreed, though, to understand the biology and what effect our treatments have, we need to follow the trajectory of our patients. It's not all about measuring it at baseline. And this is complicated. How do you follow patients over time, the trajectory analysis? There are multiple techniques available, and we started hearing about some of them, some new ideas. This idea I had not heard of before, dynamic time warping, but essentially meaning not just taking clusters of patients at baseline, but actually following their disease progress over time. And we can follow these different groups over time and understand those subphenotypes. Those clinical trial designs, we discussed many different options, but it comes down to, I think, some simple levels where if we have a biomarker we're sure is going to determine response, we can select just that group of patients for that trial, enrich our population to show benefits from our treatments. Where we're less sure, we can bring both groups, biomarker positive and negative, into the trial. We randomize our patients, still learning. And if we realize it doesn't work in one group, we can have these adaptive designs where we perhaps drop that arm and still continue to find the right treatments for the right patient. But we could also consider other ways. Many people are involved in this paper led by David Maslow last year, which suggested that maybe we could redefine critical illness from our syndromes. That many of our clinical syndromes have overlapping biological mechanisms, and the idea of a treatable trait. So if you had a patient here who has a certain biomarker profile, it may be similar for trauma, infection, surgery. The idea of having a treatable trait, this point D, may be treated with drug D. And then you could include them in a basket trial where you included them as long as they're biomarker D positive, it doesn't matter, trauma, pancreatitis, surgery, infection, all come in and test whether these drugs might work. We realize, though, this is exciting, but we need to be careful and beware of the pitfalls. Any models are influenced by the characteristics of the data going in, so we need to make sure we've included the right data and don't want to exacerbate medical disparities. We need to update all the time as we learn more, update our diagnostic systems. And although they may be complex, we can still ensure transparency, and reproducibility is always key. We had Janet Diaz from the WHO talking to us, encouraging us to learn on the experience of COVID-19 and how we've seen critical illness affects us at a global scale, and can we learn about it disseminating all of this throughout the world. So in summary, we did agree a few things over the weekend, that we need a better targeted treatments, we need to agree on our terminology and taxonomy and harmonize these subtypes, and it may include different sets of data, and that will involve working with data scientists and informaticians. We need that international cooperation and sharing our values, making sure there's equity, generalizability, and impact on the population. We need to continue to develop our indicators of treatment response, look at trajectories, understand mechanisms better. We generally talk about blood, but what about the other compartments? But we feel the time to start testing prospectively is now. We're still learning, but we can, while we start implementing these new paradigm, learn, and we will iterate it over time. Even if we wait, we know even the best models, all models are wrong, but some are useful, and we need to learn that. So our next steps is to help bring into clinical practice and into trials these conceptual frameworks and investigational pathways so that we can actually implement them. Probably to achieve this, we need an independent infrastructure to allow this collaboration and cooperation. And our first step in that will be to disseminate this work, not just here, but through a publication. And a final slide, just to say we did think about this new technology, the data approaches, and how AI can help us. And it can help us do things better for our patients. But even in this room, what we did along the lines of Fabio's example, asking ChatGPT to help us, I don't think any 24 intensivists would have come up with a poem about sepsis and precision medicine, but it did very quickly. Sepsis is a sickness that can be very tough, but doctors and scientists are working hard enough to find the different types and figure out a plan to help people heal and feel better again. It's like a puzzle they need to solve to crack the code and get involved. But with their knowledge and their care, they'll help us beat sepsis. That's their dare. So I encourage you, are you going to dare and come with us on this journey? Thank you.
Thank you very much. It should have been a very encouraging roundtable. So it's my pleasure now to introduce Dr. Ewan Gallagher from Toronto on the heterogeneous effect of heparin in patients with severe COVID-19.
Good morning. It's my pleasure on behalf of the REMAP-CAP, ATTACK, and Active-4A investigators to present this study entitled Heterogeneous Treatment Effects of Therapeutic Dose Heparin in Patients Hospitalized for COVID-19, which is simultaneously being published online in JAMA. So the problem we take up in this paper is very much the one that was discussed at length over the weekend in the roundtable, which is this issue of heterogeneity of treatment effect. And with respect to what randomized trials report, they report primarily a single estimate of treatment effect, which might be termed the average treatment effect in the trial population. But in truth, we know that the treatment effect can vary markedly between individuals. So in this hypothetical trial shown in the plot on the right, the mortality rate in the intervention control groups is the same, so the average treatment effect might be said to be null. But that could be decomposed into subgroups where some patients are benefiting and some are harmed, and consequently the results of the trial may be misleading for specific subgroups of patients. Why does this occur? It's because trial populations, particularly with heterogeneous critical illness syndromes, represent a mixture of patients with widely varying relevant characteristics. And this is represented symbolically by the plot on the right, where patients who randomize to treatment or control have a variety of relevant characteristics, such as the number of organ failure, severity of hypoxemia, or by sex. And if those characteristics exert competing effects on the treatment effect, then that introduces significant noise into the trial, which attenuates and modifies the overall observed effect. Now, the standard noise reduction strategy in the analysis of clinical trials is conventional subgroup analysis, where sources of heterogeneity are considered but one at a time. And because it's one at a time, you might refer to this as a one-dimensional approach. And there's important limitations attached to this. So for example, when you do a one-at-a-time subgroup analysis, there can be substantial residual heterogeneity as represented by the plot where now we're conditioning on severity of hypoxemia, but there's still substantial variation within the subgroups. And because each subgroup effect is considered separately and no one subgroup effect is pre-specified as the primary analysis, you're vulnerable to a significant increase in type 1 error and all the problems attached to multiple hypothesis testing. So such analyses are generally considered exploratory and hypothesis generating. A much stronger potential approach would be to use what one might call multidimensional HT analysis. And here the goal is to estimate what is called the conditional average treatment effect. This is the treatment effect that is simultaneously conditioned on multiple characteristics. And the plot here on the right now represents all of the subgroups separated out or conditioned on every combination of characteristics. And this might allow you to see how the treatment effect varies according to all combinations of relevant characteristics. But there are challenges, of course, to doing this. So which characteristics or phenotypes need to be considered? How do we combine these together in a single model to get a primary pre-specified analysis? And if we use different approaches to doing this, do we get consistent results? So we set out to address these questions in an exploratory secondary analysis of the multi-platform randomized trial of therapeutic dose heparin for moderate or severe COVID-19. As you may recall, these this trial was published as two separate papers, one in the moderate state, one in severe. in August of 2021. And we found significant heterogeneity. In the moderate state, there was a high probability of benefit. In the severe state, a high probability of harm. But because these patients were all enrolled and randomized in one overarching multi-platform trial, it occasioned a good opportunity to look at how these HTE analysis techniques would perform. And in particular, our goals were to establish empirically the threshold of severity distinguishing benefit and harm, and to look at consistency across the methods. So in this paper, to estimate the conditional average treatment effect, we used two approaches. The first is what is called risk-based analysis, where you use a single effect modifier variable, which is quantified in terms of the risk of poor outcome. So multiple patient characteristics are combined into a single model that predicts risk, where the risk is represented by a risk score, and then the observed treatment effect in the trial is stratified by the risk score to look at risk-based HTE. A second approach is what is called the effect-based approach to analysis, where the single effect modifier is the predicted treatment effect. And again, multiple characteristics of patients and disease state are combined using causal forest analysis to estimate the predicted treatment effect. And then again, the observed effect is stratified by the predicted effect to look at HTE. So here are the results. The average treatment effect in the overall multi-platform trial was consistent with a neutral, non-significant effect, an odds ratio of 1.05, so a low probability of superiority. Using conventional subgroup analysis, we identified a number of possible predictors of heterogeneity of treatment effect. For example, body mass index seemed to have a significant influence on treatment effect. Patients with low body mass index were much more likely to experience benefit from therapy. Treatment effect also differed according to sex and according to severity of illness, as we'd expect based on the primary reports. And here again, it's patients on no or supplemental oxygen who are likely to benefit from therapy, and other patients more likely to be harmed. But using the risk-based approach to analysis, you see the true spectrum of heterogeneity across the spectrum of risk. The results of the risk-based analysis are represented here according to deciles of risk score. So the lowest risk patients are in the first decile at the top, and the highest risk patients at the lowest decile on the bottom. And you can see that across the range of risk, the treatment effect monotonically varies according to predicted risk. Patients in risk group 8 to 10 were at a substantial probability of harm, and all of these patients were on high flow nasal cannula or higher levels of respiratory support. By contrast, patients in risk groups 1 through 6 all had a fairly high probability of benefit, and none of these patients required higher levels of respiratory support. In the risk model, the major predictors of risk and therefore of treatment effect were age and again body mass index and the baseline level of respiratory support. Finally, in the effect-based approach, using causal forest model, the most influential predictors of outcome were, again, the predicted risk of a poor outcome or severity and the body mass index. And the results of the effect-based analysis are represented the plot on the right, this time looking at a different outcome, the absolute difference in survival rate. Because of the nature of causal forest modeling, we looked at an absolute difference in survival. And although the observed effect is not monotonically related to the predicted effect, in the lowest predicted effect decile, there was a significant difference in treatment effect in comparison to the other patients. And patients in this decile had much higher body mass index and a higher baseline severity of illness, again identifying the same factors driving HTE. So to summarize the findings of this study, we identified some key consistent predictors of heterogeneity of treatment effect across the different methods, body mass index, and the severity of illness as best represented by the level of respiratory support at baseline. And given the fact that the overall average treatment effect in the multi-platform trial was neutral and that there was such significant heterogeneity of treatment effect, in retrospect, we can say it was truly fortuitous that the investigators chose to stratify the treatment effect in the primary analysis by severity when the trial was initially designed. In essence, we got very, very lucky. And this, I think, should prompt some soul searching about our general approach to interpreting and deriving meaning from randomized clinical trials. I would submit that the relevant estimate from trials is not so much the average treatment effect in the population, but the conditional average treatment effect conditioned on characteristics that are relevant for patients and clinicians making medical decisions at the bedside. So we would propose that conditional average treatment effects be routinely pre-specified and reported in the analyses of trial, and there is potential in the future to incorporate real-time HTE analysis into the design of adaptive trials to uncover treatment-responsive phenotypes and to adapt the trial accordingly. I think the potential impact here is significant. We may, as a result, have more informative randomized trials with fewer quote-unquote negative results. And for some truly salient examples, you could look at recent HTE reanalyses of the BASICS and BOUGIE trials that were recently published. And overall here, the potential impact is a more personalized approach to treatment for safer care, better outcomes, and a greater return on investment for the healthcare research enterprise. I'd like to thank the many people who are involved in the multi-platform trial and in this work in particular, and my co-authors and our superstar statisticians for their work in getting this to completion. Thank you very much.
Thank you very much, Dr. Gallagher. Our next speaker is Dr. Jalali Anani, who's coming to us from Paris, France, and he will be speaking to us on intravenous ravulizumab in mechanically ventilated patients hospitalized with severe COVID-19.
Thank you. Good morning, dear colleagues. It's my privilege to stand this morning on behalf of the ravulizumab for severe COVID-19 study investigators. So I'm going to summarize the take-home message from that trial, and full information is available online at Lancet Respiratory Medicine since last night. So let's start again by remember you that the complement pathway likely play a role in driving the progression from an asymptomatic SARS-CoV-2 infection to critical COVID-19. As you know, the terminal complement pathway may play a major role in regulating inflammation, and in particular the anaphylatoxin C5a. So basically, ravulizumab is a monoclonal antibody that blocks C5, and by that means may control the upregulated terminal complement pathway, driving complication in severe COVID-19 patients. So the objective was to evaluate the effect of ravulizumab on top of best supportive care in survival in patients with critical COVID-19. So the patients were receiving 4 doses of ravulizumab every over 5 days in an open label manner, and with a 3 days, up to 3 days screening period. The primary efficacy was assessed at day 29, and patients were followed up to day 90. So again, the primary outcome was survival based on all-cause mortality at day 29. You can see this few secondary outcomes, and we also looked at pharmacodynamics. The planned interim analysis was conducted in January 2021. At that time, 122 patients had completed the primary evaluation, and the independent data monitoring committee recommended stopping the study as the trigger for futility was reached. By the time that enrollment was stopped, there were 202 patients in the study. So here is the main characteristic at baseline. No surprise in terms of profiles, more male, an average of 63 years old. The vast majority of patients had comorbidities, among them hypertension and diabetes mellitus were the most frequent. And also of note, there was some imbalance at baseline with significantly more patients being in shock or having deep vein thrombosis in the experimental arm. At baseline, as I mentioned, all the patients were admitted to the ICU. The vast majority were on invasive mechanical ventilation with low PF ratio, high SOFA score, and an average time from the start of the symptoms of 11 to 12 days. The main results are as shown in this table, so there were no evidence for any difference, either clinically or statistical difference in between the 2 treatment arms, with regard to the primary outcome and regardless the way we looked at the primary outcome. And for that reason, we did not perform any other analysis for statistical analysis for the secondary outcomes, of course. So the Kaplan-Meier survival curve is clear. There's absolutely no evidence that the two arms separate at any time during the follow-up. Interestingly, this is not related to the fact that the drug has no biological activity. As one can see here, the C5 concentration were extremely high in both treatment arms. One can see that ravulizumab was associated with a rapid and full blockade of a terminal complement pathway that remains sustained even beyond the end of the 5 dose of ravulizumab. By contrast, in the control arm, one can see how sustainedly the complement pathway remained activated up to 1 month after the randomization. So the drug was biologically active. The drug was overall well tolerated. One can see the treatment-related adverse events. Most of them were hypertension, respiratory failure, or atrial fibrillation with roughly similar events in both treatment arms. There were a higher incidence of septic shock and sepsis and DVT thrombosis. Again, this was already present at baseline. So roughly, the tolerance of treatment was very in line with what's known with this type of drugs. And the study also has value for future research into complement therapeutics in critical illness by showing that C5 inhibition can be successfully accomplished in critical ill patients. And again, it's important to let you know what is up to now the current drugs available to regulate or to manipulate the terminal complement pathway. And you can see that all of them have been investigated with variable outcomes in severe critical patients, with the vilobelimab study showing potential survival benefit by blocking specifically the C5a and not C5 itself. And that's my final slides for acknowledgement and disclosures. And I hope you will have a good meeting. Thank you very much.
Thank you very much, Gilalis. Now my pleasure to introduce Nicolas Hemming from the same unit, Paris and USQ University. And this is going to be on hydrocortisone in severe CAP.
Good morning. Thank you for giving us the opportunity to share these findings, which you can find in today's New England Journal of Medicine. So I'm presenting these data on behalf of Professor Dequin, who's unavailable, unfortunately, today. Okay, these are our conflict of interests. So, as you know, few randomized control trials have successfully assessed the usefulness of corticosteroids in community-acquired pneumonia. Therefore, we undertook this trial, which was a blinded, randomized control trial, which aimed to determine whether the early administration of hydrocortisone compared to placebo improved mortality in patients with community-acquired pneumonia admitted to the ICU. Inclusion criteria were severely affected patients admitted to the ICU for community-acquired pneumonia. Severity was defined by one of these 4 criteria: either the need for mechanical ventilation, invasive or non-invasive, a PF ratio below 300 if patients received oxygen through a high-flow cannula, an estimated PF below 300 when patients received oxygen through a non-rebreathing mask, or a PSI index over 130. The main non-inclusion criteria were do not intubate orders, influenza-related pneumonia, and septic shock. However, vasopressors were allowed to mitigate sedation or positive pressure-related hypotension. The intervention was continuous IV administration of hydrocortisone in the intervention group versus placebo. The treatment was started within 24 hours of the first sign of severity, and treatment was discontinued upon discharge from the ICU. As you can see, the standard duration of treatment was 14 days. However, on day 4, the investigator could decide, following predefined criteria, to reduce the length of administration. This happened mainly in patients who were improving substantially by day 4. And as you can see, there was progressive tapering of the dose of hydrocortisone over time. These are the outcomes. So the primary outcome was all-cause mortality on day 28. The sample size was calculated using or estimating that the mortality on day 28 would be 27% in the control group. We were expecting a 25% relative reduction of mortality in the experimental group. Power was fixed at 80%. 2 planned interim analyses were planned. And so overall, more than 1,165 patients were required, which was rounded up to 1,200 patients to account for lost to follow-up patients. The first patient was included at the end of 2015. The last patient was included at the end of 2019, at the time of the second planned interim analysis. No patient suffering from COVID was included in the current trial. Overall, 5,948 patients were screened. 800 patients were randomized. Out of these 800 patients, 400 were included in the hydrocortisone group in the primary analysis. 395 were included in the placebo group in the primary analysis. And as you can see, the main causes for exclusion were septic shock, aspiration pneumonia, patients who were not severe enough, influenza, etc. These are the characteristics of the patients at the time of inclusion. The median age was 67. Approximately a third of the population was female. As you can see, respiratory support was similar between both groups. Mechanical ventilation was a strata of randomization in this trial. Severity scores were also similar between both groups at inclusion. The primary endpoint, day 28 mortality, was 6.3% in the hydrocortisone group versus 11.9% in the placebo group. The absolute difference was 5.6% in favor of the hydrocortisone group. P was statistically significant at 0.0055. Our secondary outcome, day 90 mortality, was also in favor of the hydrocortisone group. Mortality on day 90 in the hydrocortisone group was 9.3. In the placebo group, mortality at day 90 was 14.7. Absolute difference 5.4 in favor of hydrocortisone, P at 0.02. Secondary outcomes of note were also in favor of the hydrocortisone group. So among patients who were not intubated at the time of randomization, there was less need for intubation during the trial. There was less need for vasopressor support during the trial in the hydrocortisone group. And the duration of stay in the ICU was shorter in patients treated by hydrocortisone. Safety outcomes. The incidence of hospital-acquired infection did not differ between both groups during the trial. However, the daily dose of administered insulin was higher in the hydrocortisone group than the placebo group, indicating compliance with the treatment. This is an expected secondary effect of corticosteroids. Some limitations of the trial. Observed mortality was lower than estimated at the start of the trial, especially in the control group, despite including a high-risk population. This occurred probably because we excluded patients suffering from septic shock. A few immunosuppressed patients were included in the trial. There was no assessment of the neuromuscular effects of corticosteroids, and the continuous infusion and tapering of the drug is questionable. Our conclusion is that in patients with severe CAP admitted to the ICU, early treatment with hydrocortisone compared to placebo significantly improved day 28 mortality. Thank you.
Thank you so much for that wonderful talk. Our next speaker is Pierre Bouzat, and he's coming to us from Grenoble, France. He will be talking to us this morning on early administration of prothrombin complex concentrate in trauma patients at risk for massive transfusion.
Good morning, ladies and gentlemen, dear colleagues. It's an honor to present the result of the PROCORACT trial, and I would like to thank the organizing committee and the JAMA Journal that allows me to present those results. It's such an opportunity. So the PROCORACT trial deals with the efficacy and safety of 4-factor PCC in patients at risk of massive transfusion, and the paper is published right now online in the journal. So the rationale behind the PROCORACT trial is that the optimal transfusion strategy in severe bleeding trauma patients remains unknown. Different strategies have been proposed, and they all share the rationale to administrate coagulation factor as soon as possible. For factor PCC, which contains activators and inhibitors of the coagulation pathway, can be an option. It may boost thrombin generation in patients with acute severe bleeding. But there are still concerns regarding potential thromboembolic complications, and that's why we decided to design the study. To reinforce the rationale of the study, this study has been published last year. This was an analysis of a registry based in the US, a trauma registry. And as you can see, the authors compared patients treated with 4 factors PCC plus FFP versus patients treated with FFP alone. And what they found is a reduction of a total blood consumption in 24 hours, and they also shown a decrease in hospital mortality without any increase in thromboembolic complication. So the randomized controlled trial appears justified to test the efficacy and safety of 4-factor PCC. Oh, sorry, it doesn't work. So, okay, I checked the slide, but it doesn't work. So we designed a superiority randomized controlled trial, a double blind. We enroll adult patients at risk of massive transfusion. The risk of massive transfusion was defined by a transfusion of at least 1 RBC in the pre-hospital field or within 1 hour after hospital admission. And the patient should also have an ABC score for assessment of blood consumption score higher than 2. And the investigators could override the ABC criterion if the clinical judgment was in favor of a risk of massive transfusion. The study took place in 12 trauma centers in France. And we totally enrolled 302,007 patients. And we finally analyzed 324 patients, since 3 patients withdrew their consent. So 164 patients were allocated to the 4-factor PCC group, and they received 1 milliliter of kilogram of 4-factor PCC. and 160 patients were allocated to the placebo group and received 1 milliliter of kilogram of placebo. Both arms were treated according to European guidelines with tranexamic acid, a ratio-based transfusion, and fibrinogen concentrate were appropriate. The sample size of 324 was calculated to observe a reduction of 25% of total blood consumption, a decrease from 12 units to 9 units of total blood consumption. Here are the baseline characteristics. The typical patient included in the study was a young male suffering from blunt trauma. There was a slight imbalance between the systolic arterial blood pressure between the 4-factor PCC group and the placebo group, but on arrival on the trauma base, the systolic arterial blood pressure was the same between the two groups. And there was a higher proportion of patients treated with TXA in the placebo group compared to the 4-factor PCC group. Patients had a very high traumatic load. Median lactate concentration was 5 millimeters per liter. 1/3 of the patient had a fibrinogen concentration lower than 1.5 grams per liter. The PT ratio was higher in 1.2, defining acute post-traumatic coagulopathy in around 65% of the patient, and the median ISS was around 35, with 1/3 of patients suffering from severe traumatic brain injury. Regarding resuscitation indicators, 70% of patients need an hemostasis control procedure, surgical or radiological. 40% of the patient had a transfusion of at least 3 units of RBC within the first hour after arrival in the trauma bay, and 25% of the patient had massive transfusion defined by 10 units of RBC or more within the first 24 hours. The same proportion of patients were treated with fibrinogen concentration, and there was a slight imbalance between the total dose of fibrinogen concentrate between the two groups, but which was not clinically significant. So regarding the primary outcome, the total blood product consumption was not different between the two groups, with 12 units in the placebo group versus 11 units in the 4 PCC groups. The separate analysis of the blood consumption shows also no significant difference in terms of red blood cell transfusion, fresh frozen plasma, and platelets. Regarding time course of PT ratio, as you can see, there was no difference in terms of time course of PT ratio between the two groups. Even we've seen a faster correction of PT ratio in the 4-factor PCC group. The PT ratio was not different at 12 and 24 hours between the two groups, and the time to obtain a PT ratio lower than 1.5 was not different between the two groups. We have the same results in the per protocol analysis, which were patients treated within the first hour after admission, and in the subgroup of patients with massive transfusion. Regarding safety outcomes, we found a higher proportion of patients with at least one thromboembolic event in the 4 PCC group, which was 35%, versus 24% in the placebo group with a p-value of 0.03. A post-hoc analysis revealed higher proportion of thromboembolic events in patients with a PT ratio as higher than 1.2, in patients that receive 4-factor PCC, 35% versus placebo, 22%, with a p-value that almost reached statistical significance. The 24-hour mortality was not different between the two groups, and the 28-day mortality was also not different between the two groups. We don't find any difference for other secondary outcomes, such as ICU 3 days, ventilator 3 days, or hospital 3 days. So to conclude, in trauma patients at risk of massive transfusion, a systematic use of 4-factor PCC did not decrease total blood product consumption at 24 hours. The same effect was found in patients with massive transfusion. More thromboembolic events were reporting in the 4-PCC group, particularly in patients with a PT ratio higher than 1.2, highlighted that the fact that maybe we gave substrate to an already activated thrombin generation. The main limit of the present trial is that no viscoelastic testing was used to guide the administration of 4-factor PCC. And I think the trial showed that there is no indication of systematic administration of 4-factor PCC in patients at risk of massive transfusion. I would like to thank you for your attention. I apologize for my slide, which was very bad. Thank you.
Thank you very much. We are now inviting Dr. Jan Grunst from Louvain to present on tight glucose control in patients not receiving parenteral nutrition.
Thank you for the introduction, and I want to thank Professor Jean-Louis Vincent, Professor Fabio Tacconi for the opportunity to present the first results of the TCC FAST randomized controlled trial. I have no conflicts of interest with regard to this presentation, and the study was solely financed by academic and non-commercial grants. Numerous observational studies have shown that there is a U-shaped relationship between blood glucose concentrations in the ICU and the risk of mortality, whereby the lowest risk of mortality associates with normal blood glucose concentrations. However, these are observational studies, of course, and from these data, one cannot know whether hyperglycemia directly impairs outcome or not, as this requires a randomized controlled trial. And this was first studied in the Leuven RCTs by Professor Greet van den Berge, in which she randomized critically ill patients to tight glucose control, in which normal blood glucose concentrations were targeted, or to tolerating hyperglycemia up to the renal threshold. And in 3 randomized controlled trials, Professor van den Berge showed that tight glucose control significantly improved the outcome of critically ill patients. However, the benefit was not confirmed by multicenter RCTs, and the largest RCT so far, the NISUGAR study, actually showed increased mortality by tight glucose control. The NISUGAR investigators subsequently attributed the increased mortality risk to increased risk of hypoglycemia, and the NISUGAR protocol has been criticized for its relatively high incidence of hypoglycemia. In Leuven, the glucose control protocol was highly standardized and episodes of hypoglycemia were mostly brief. However, the Leuven protocol has been criticized for its early use of full nutrition via supplementary early parenteral nutrition. And this feeding practice was in subsequent trials shown to be harmful. And the current feeding practice of not giving early parenteral nutrition lowers blood glucose and increases the risk of hypoglycemia. So it remains unclear the efficacy and safety of tight glucose control when glucose control is provided with a validated protocol that minimizes the risk of hypoglycemia, but in patients who do not receive early parenteral nutrition, this remains unclear. And this important study question was actually studied in the multicenter TCC FAST randomized controlled trial. And in the trial, we randomized adult critically ill patients to tight or liberal blood glucose control. In the tight group, we aimed at normal blood glucose concentrations, and in the liberal group, hyperglycemia was only treated when it exceeded 215 milligram per deciliter. Patients did not receive early parenteral nutrition. However, in patients who stayed for more than 1 week in ICU and patients who still had insufficient intake via enteral or oral nutrition, they were started on supplemental parenteral nutrition after 1 week in ICU. And as the intervention, tight glucose control may have a different impact depending on the amount of feeding provided, we pre-specified to study whether the intervention may have a different effect in patients with a predicted short ICU stay versus a predicted long ICU stay. In the tight group, tight glucose control was guided by the logic insulin algorithm. And this algorithm was previously validated in a multi-center RCT in patients who did not receive early parenteral nutrition, and use of the algorithm was shown to lead to well-controlled glucose concentrations with a very low risk of hypoglycemia. In the control group, in the liberal arm, an alert was implemented in the patient data management system to maximize the protocol compliance in order to only administer insulin when it was needed to prevent severe hyperglycemia. The study protocol and statistical analysis plan have been published. In total, we randomized 9,230 patients to receive tied or liberal blood glucose control. Baseline characteristics were comparable between both groups, and approximately 1/3 of patients had a predicted ICU stay of more than 1 week in ICU. And the prediction was done by a computer algorithm, and this algorithm only made use of baseline of upon admission characteristics. Patients in the trial did not receive early parenteral nutrition, but of course there were some patients who, after 1 week in the ICU, did not receive their caloric target via enteral or oral nutrition. So these patients were started on supplemental parenteral nutrition after 1 week, and that's why the parenteral nutritional intake increased in the 2nd week in ICU. The insulin doses significantly differed between both arms. Whereas the vast majority of patients received insulin in the tied group, less than half of patients received insulin in the liberal group. And in parallel with the increased nutritional intake in the 2nd week in ICU, also insulin doses increased. Blood glucose was similar upon randomization, and thereafter was significantly different between both groups. In the tied group, blood glucose was lowered to the normal range, and it remained elevated in the liberal glycemic control group. You see that from day 3 to day 7 approximately, that there is a relative dip in blood glucose, and this dip was not present in the original Leuven RCTs, and this difference is likely explained by the lower nutritional intake in this trial. And as you see, in parallel with the increased nutritional intake in the 2nd week, also the glucose concentrations are higher again in the 2nd week in the liberal group. The incidence of hypoglycemia was very low in both groups, and there was actually no statistically significant difference in hypoglycemia. Only 1% of patients in the tied group developed hypoglycemia in ICU. Mortality was a safety endpoint in the trial, and there was no impact of the intervention on ICU mortality, hospital mortality, and 90-day mortality. The primary endpoint was a duration of ICU dependency, which we studied as the length of ICU stay and as the time to being discharged alive from ICU, and the latter is to correct for mortality as a competing risk. And there was no impact of the intervention on both parameters. However, tied glucose control significantly reduced the incidence of severe acute kidney injury and the need for new kidney replacement therapy, and it significantly reduced the incidence of cholestatic liver dysfunction. And in patients with a predicted long ICU stay, the effect size of the intervention appeared to be larger. However, also in patients with a predicted short ICU stay, there was the incidence of severe acute kidney injury and of cholestatic liver dysfunction was significantly lower in patients receiving tied glucose control. So in conclusion, in the absence of early parenteral nutrition and guided by the logic insulin algorithm that virtually avoids hypoglycemia, tied glucose control did not reduce the duration of ICU dependency, but it was safe with regard to mortality, and it reduced severe acute kidney injury and cholestatic liver dysfunction, irrespective of the predicted duration of ICU stay. Excess mortality by tolerating hyperglycemia in the original Leuven RCTs is explained by hyperglycemia that is aggravated by the use of early parenteral nutrition. I want to thank all TGC FAST investigators and all people who contributed in the trial. Of course, there were many, many people who contributed. I want to thank all the clinical teams, the research teams, database manager, IT support, and TGC FAST patients and family members and members of the DSMB. Thank you very much.
Thank you very much. Our next speaker is Jean Renier, and he'll speak with us about low versus standard calorie and protein feeding in ventilated adults with shock.
Well, good morning, and thank you for giving me the opportunity to present the data of the NITRIA trial. Yes, during decades, or for a long time, hypocaloric feeding was in ICU was associated with adverse outcome due to the results of numerous observational studies. In the last decade, randomized controlled trial demonstrated opposite effects. Complemental parenteral feeding was associated with delayed recovery and increased risk of infection. Permissive hypocaloric feeding was not associated with adverse outcome. On trophic hypocaloric feeding with amount of calories as low as 400 kilocalories per day was not associated with adverse outcome, including long-term outcome. Regarding protein doses or intake, it was also surprising and unexpected that data showed that higher protein doses were associated with greater muscle wasting and delayed recovery. So the question was, less is more in nutrition, but the optimal strategy for providing calories and protein in critically ill patients was not known at all. Oh, doesn't work. Okay. But the question was, how much less calories and proteins is more for the critically ill? So we designed this study, the NITRIA 3 randomized trial, to test the hypothesis that low-calorie, low-protein feeding during the first week in ICU improves the outcome of patients with acute critical illness requiring mechanical ventilation and catecholamines for shock as compared to normal calorie, normal protein feeding. The 61 studies centers participate in France, and the study was supported by a grant of the French Ministry of Health. The paper is now available on the website of the journal, The Lancet Respiratory Medicine. So patients were randomized into two arms. In the standard group, they received 25 kilocalories per kilo per day and 1 to 1.3 grams per kilo per day of proteins during the first week in ICU. And in the low group, they received 6 kilocalories per kilo per day and 0.2 to 0.4 grams per kilo per day of protein. They could receive more during the first week in the low group if they were extubated and if vasoactive support was discontinued. At day 8, so after the acute phase, the target was 30 kilocalories per kilo per day on 1.2 to 2 grams per kilo per day of protein. The inclusion criteria, we included adult patients receiving invasive mechanical ventilation started in the ICU within the past 24 hours, treated with vasoactive agent for shock, and with the nutritional support that expected to be started within 24 hours after intubation. We evaluated two primary endpoints, the all-cause mortality by day 90 and the time to discharge alive from the ICU, which was defined according predefined criteria. The patient had to be no longer in need for invasive mechanical ventilation, no longer in need for vasoactive support, should not be agitated or have altered consciousness, recurring monitoring, and should have no severe acute metabolic or hematologic disorder. Briefly, we calculated that 344 patients should be included to demonstrate a difference between groups for the two criteria. And as you see, the inclusion rate was very nice, and inclusion stopped at the end on 2020. The demographic characteristics of the patients are not surprising. We included patients, the mean age was 66 in both groups, a majority of male, and it was very severe patient with SAPS-2 of 60 on SOFA score of 10 in both groups, and the main cause of shock was sepsis, almost 60% in both groups. The adherence to the study protocol was very good, with calorie and protein intake very close to the target, and a very nice difference between groups during the first week, as indicated by the protocol. There was no difference for day 90 mortality between groups, which was 41.3 in the low group and 42.8 in the standard group. And however, the time to readiness for ICU discharge was lower in the low group as compared to the standard group. Regarding the key secondary outcome, you can see that time to weaning from mechanical ventilation was also lower in the low group as compared to the standard group. And that highest glucose level was higher in the standard group, and those patients received also more frequently insulin. However, there was no difference in rates of patients with hypoglycemia in both groups. In the maximum blood lactate level was higher in the standard group as compared to the low group, and patients with normalization of the blood lactate level, the rate was more frequent in the low group as compared to the standard group. Note also that there were more patients with hypophosphatemia in the standard group as compared to the low group. However, no difference in the a faster decrease in the SOFA score during the first week in the low group as compared to the standard group. There was no difference in terms of infection, slightly lower rate of patients with ICU-acquired infection in the low group as compared to standard group, but this was not significant. But a higher rate of gastrointestinal and liver complication in the standard group as compared in the low group. In conclusion, data shows that low-calorie, low-protein feeding compared to standard calorie protein intakes during the acute phase of critical illness may be associated with faster recovery and fewer complications. Thank you.
Thank you very much, Jean. It's now my pleasure to invite Professor Katarzyna Kotwis for the Max Harry-Whale lecture on equity and equality in the ICU.
Good morning, everyone. Thank you very much, Professor Jean-Louis Vincent and Fabio Taccone, for inviting me to give this lecture on a topic that is now a river that flows through the world, and maybe not just one lecture might not be enough. I declare no conflict of interest regarding that topic. First, we need to concentrate on the definitions. Equality is the central principle of democracy, and it states that people should have the same opportunities to be successful and productive in their lives. And equality is the key notion that shows us that everyone will be able to achieve only based on their efforts and contributions to the society instead of their status or position. Equity, on the other hand, is not equal. They are not synonyms, obviously, and it recognizes that not everyone stands in the same place in the society, and we don't start in the same place. There are adverse conditions and circumstances that make lives challenging for certain groups of people to achieve the same goals, and this comes historically, politically, into disadvantages for those groups to be more successful. So when comparing those two terms, equality should be about giving everyone the same exact resources, whereas equity is about allocating these resources based on every individual need to have a liberal and diverse world. The complication around the world comes, as already mentioned, from political backgrounds and from different points of view, as not everybody and not all systems agree on what is just or fair per the equity definition. So there are subjective concepts, and as a result, laws and policies attempt to achieve equity have been challenged or have been highly controversial or non-existent in some places. Why has the interest in equity surged recently? Obviously, the COVID-19 pandemic has brought light to the subject that minority groups undeniably have social inequity when it comes to healthcare access across racial and ethnic minorities, and also there are historically oppressed groups that have not only fought for equality, but not have come to achieve the equity, both at peace and at war zones and across the world. Another reason, 2021 podcast, a JAMA tweet and podcast suggested that there is no structural racism and that no physician is racist. This has brought a lot of discussion about deeply embedded structural racism in editorial boards and in healthcare as such, and has shown that editorial boards of major journals that we rely on are overwhelmingly white. So there has been health disparities and racial disparities that are that we shed the light on. And after accusations of structural racism, the JAMA editor has been made to resign, and now Kirsten Bibbins-Domingo has taken the place, as we need new voices in these conversations. There's also a large gender gap in critical care medicine, as the proportion of female critical care physicians ranges from 26 to 50% worldwide. The rate of female authors of scientific publications is only 30% as first author and 15% as the last. The European Society of Intensive Care Medicine affiliated societies analysis has shown that there are only 15% of women among presidents and only 1/3 among the editorial board members worldwide. There are continents and places where there has never been a female president or a gender diverse president within the society. So this is the representation that I have already mentioned, gender breakdown per region. As you can see, the predominant composition of the European Society of Intensive Care Medicine associated societies, regional societies, is predominantly male. Gender distribution across intensive care medicine as presidents, there is as little as 0 in Africa and 20% in Europe or in South America. This comes into contrast on the entrance, because women medical trainees at the entrances to medical schools across the world now outnumber the men that qualify, get through the medical school and finish that medical school. And yet, on the other hand, there are more men than women in clinical and academic leadership positions. And how does that spread around the world? It is 1/3 of critical care trainees in the US and 1/4 of trainee intensivists in the UK, but only 20% of those get to the consultant level. In Australia, 40% of trainee intensivists were women, but only 12% of the ICU directors were women. According to the Global Gender Gap Report published in 2021 by the World Economic Forum, the average distance to gender parity is 32% globally, and it will take 136 years to close that gender gap worldwide, and I don't think we have that much time. So, ISICEM and Canadian critical care societies, Scandinavian societies, and different societies around the world have reached out to target the parity in all fields, including leadership positions in the society's journals, conferences, and other academic and administrative ranks. So what can be done? When we look at peer-reviewed journals, there should be quotas used for editorial boards, same as for the scientific societies, with announcement of rates of women among members, boards, and committees. With the national, international conferences, by definition, there should be quotas for women speakers and in chairs. So practical strategies for improving gender equity is sharing the experience and making female role models visible by showing recipes, by sharing true stories, implementing targets that we have already mentioned, embrace sponsorship for women, undertaking unconscious bias training. So lectures like this might not be enough. We might need courses on equity and equality, just like we have on hemodynamic monitoring or neuromonitoring in the ICU. So institutional support comes in place, and of course, it will take many men to be engaged to help the women to proceed. Looking at the subject more generally as equity in healthcare, we need to understand that there are differences in access, there are differences in treatment, and obviously differences in outcome. As per access, the current health expenditure as percentage of gross domestic product for year 2023, this is live data from the World Health Organization, shows there are disparities and differences across the world. And we know that provision of care to critically ill patients is the most expensive because resources for critical care vary considerably, and there are differences, 5-fold or 100-fold differences between Western Europe and some regions of Africa or South America. With ongoing war, conflicts, and problems that touch the least developed countries, we must acknowledge there is little infrastructure to deliver healthcare, especially focusing on ICU. There will be not enough ICUs which are poorly organized, not enough specialty trained intensivists. There are simple problems like oxygen and power shortage or transportation that is dangerous at times. And obviously for those underrepresented and under-sourced populations, the pre-morbid conditions must be taken into account as malnutrition, unequal access to medical supply, and unequal access to vaccination. This leads to increased mortality. The COVID-19 pandemic has brought monumental discussion about the color of the disease, bringing up the socioeconomic factors that must be identified. And if we don't do that, we will not move with the with the problem to get it solved. So there's disproportionate impact in terms of social determinants of health, the housing, the work access. The minority communities are those that have difficulty trusting that they're actually being treated fairly, and there is belief of unequal access to healthcare. A recent systematic review that has analyzed 25 studies and included over 700,000 patients showed race-based differences in outcome between black and white ICU patients. This is a study that included American papers. So the authors have reported there was no difference in ICU mortality between racial groups after adjusting for confounders like severity of illness or hospital type. However, the socioeconomic status, healthcare access, and geographic residence are all the constituents of race that we not always adjust for. So looking at the raw data, black patients were more likely to be admitted to lower performing hospitals, experience greater financial impact after the discharge from the ICU for the whole families, were less likely to receive early tracheostomy, and were less likely to receive timely antibiotics. So analysis like this one shows that there are structural inequities. So we need new approaches to investigate and eliminate racial inequities in the ICU. This is a subject, and I bring this in memory of Dr. Curtis, who has passed away in February this year, and his research and passion has been focusing on providing equity in palliative care and intensive care. So this is one of the last papers authored by him. Researchers should give consideration to how medicine is racialized, and research around racial disparities should not exist without explicit attention to how race and racism affect the daily lives of patients of color. So we need to bring public health critical race praxis. There are 4 focus areas and 10 principles that both practicing physicians, but also those designing research should take into account and clarify how racism influences enrollment into different studies, and how we get results that do not really represent the society as such. Other levels of structural racism within the society rely on inadequate data collection, with authorities less willing to record the racial makeup of the society, or using proxies such as language or birthplace or religion or the parental composition. Now, how to mitigate the structural racism? It needs a lot of effort from the society. It needs coalitions. This is an example of a coalition that includes the health system personnel, the clinical leadership, but also the supporting parties to involve in sepsis care, to shorten the door to antibiotics time, to improve outcome and decrease mortality. So equality and equity is all about asking the right questions. There are common misbeliefs. Not everybody acknowledges the problem. There have been published papers and discussions that either people are not ready for this, or the problem does not exist, or it's an artificially created problem. But hopefully we all agree that is not the case. How to do it? By rewriting strategies for those communities that are under-resourced, underrepresented at national level and at the micro level at the community. Also by improving the trust into the healthcare system that would improve early admittance to the hospital. Now, there has been another subject brought up by researchers of color that the white scholars are health equity tourists that try to dominate or colonize research on health disparities, whereas they don't really represent a minority. But for this to be ethical and just requires to redistribute the privilege and benefit and invite everybody into the discussion. Also, another solution is to acknowledge different types of diversity. Inequity will be based on the lack of generational diversity, so not representing people from different generations or those that have got different lived experience in terms of neurodiversity. Ableism, discrimination against those that have been perceived to be disabled, and not so rare tokenism, practice that makes symbolic effort to include members of the minorities or groups that are underrepresented, that should also be brought to light and discussed. Another solution, by practicing inclusive communication that leads to lower macro and microaggression and builds trust within the workforce. And CDC has published a special document on inclusive communication. It is in English and maybe should be translated to different languages, or different countries should adopt their principles. Adjectives such as vulnerable or at risk should be avoided. We should not use dehumanizing language and use the first person language instead, remembering that there are different types of populations in research and in clinical practice, avoiding violent words like target, tackle, or combat, and obviously avoiding unintentional blaming. So why care? This is the duty of an intensive care unit healthcare team, to understand and address inequities, to improve patient outcomes by acknowledging the problem and rewriting the medical experience to those groups that have not been included, and working through patient mistrust, improving diversity, and improving social determinants of care should be our focus. And I would like to finish my talk with a quote from a Polish Nobel Prize winner in literature for the year 2019, who has been very active in both minorities research and gender parity research, who brought the light to the subject not only in Poland but across the world, that equity leads to unhappiness, and long years of unhappiness cause a person worse degradation than a fatal illness that we often treat in the ICU. Thank you.
Thank you so much, Dr. Kopfis. And I'd like to introduce our last speaker for the morning. Lewis Kaplan comes to us from the University of Pennsylvania in the United States, and he'll be speaking to us about hospital violence, critical care professionals at risk.
Thank you, Professor Gershengorn, Professor Azoulay, Professor Taccone, and Professor Vincent. It is indeed a privilege to speak with you today. You have heard grand presentations, exciting data. We're now going to have a difficult discussion about a challenging topic: hospital violence and why you and your teams are at particular risk. These are my disclosures, none of which are financial in nature, but I am a trauma surgeon, so you need to know that up front. Our objectives will be to discuss intensivists, the settings in which they practice, the violence that permeates those settings, what those consequences may be, what drives it, how you can prevent it, and what some adaptive responses that you can deploy in your facility may also be. Intensivists, as you see, will practice in some general ICUs, some specialty ICUs. It may be adult, it may be pediatric or neonatal. I call your attention in particular to the emergency department, where there are now also ICUs. Intensivists, like all of us, are trained in a parent specialty, and then we pursue additional education in critical care medicine. We then lead multi-professional teams and deliver complex care. You see some of the team members identified here. In all of those settings, every last one is permeated by violence. In fact, that violence has been categorized because it is so robustly present on the basis of the perpetrator. You will see 4 types, of which types 2 and type 3 predominate. This is patients, families, current and former employees, representing nearly 94% of all workplace violence. That violence has been explored in 5 domains since the 1970s. You see them listed here. You may have been trained on them or trained to recognize them in your hospital. It may be vertical or hierarchical or lateral between people in the same specialty and at the same station within that facility. This is Dr. Michael Wong, stabbed 13 times by a patient he was treating. He is an example of vertical violence. You will see a hashtag there, Silent No More. If you look at that hashtag, it invites you to say something and report workplace violence when you see it. This is not the most disturbing feature. There's lateral violence. This is an Army nurse set on fire by her colleagues. I call your attention to the small quotes. I knew this would happen, suggesting that this particular form of violence is both anticipatable and utterly preventable. This is under our control. And we need to address this. You're looking at workplace violence, non-fatal injuries, and healthcare outstrips all other industries by a factor of 5. That is staggering. And there are consequences to this. When you look at lost days from those non-fatal workplace violence injuries, we also outstrip all other injuries. Healthcare is in dark blue. The trend is alarming. The rate continues to rise. And therefore, when you look at physicians exposed to workplace violence, post-traumatic stress disorder is common, 1 in 6. If you're exposed to physical workplace violence, you're 7 times more likely to develop PTSD. Careful assessment will identify both anxiety and depressive features in 2 in 5, and in specialties where burnout syndrome, unlike critical care, is not common, it becomes common. And so you see, and thank you, Professor Vincent, for introducing puppies into this presentation. You see Spartacus Cooch. Spartacus Cooch is Nikita. He was at Yale with me, and he is a canine first responder. He is not there for patients. He is not there for families. He's there for you. Think about that. Not in an on-demand fashion, but a regular basis. Because workplace violence has now expanded and it follows you home. Stalking, social media, and online attacks are increasingly common. This is one example. This is a survey of almost 500 US physicians. More than half were female, and about a quarter had some social media attack. Online sexual harassment was much more common in women, but men were not immune. What were those threats? Death threats. I've had 36 across my career, but also threats of rape. This follows you where you go. The hospital comes home with you. When you think about it, intensivists are particularly vulnerable, and I deliberately use that term here. When you think about patients who have critical illness, they require complex care. This is what we do. But we also spend a lot of time communicating with patients and families, either in person or using digital platforms. Of course, patients will come to your facility as a tertiary or quaternary care center, certain if only they reach Professor Vincent's ICU, they will be saved. And when that happens, it is grand. But when it does not and the course is long, this triggers conflict. And there is no more powerful trigger for conflict than end of life. And as an intensivist and within that team, you are there with them day in, day out for many hours, and therefore you become the target when things don't work as well as people would desire. This is everybody's problem. It has been well explored and well characterized for nurses, but let's look exclusively at physicians. This is now a US study of emergency department physicians, some of whom are intensivists, comparing 2 years, 2018 in blue and 2022 in red. It asked the question about physical violence and only physical violence, looking at the frequency of assaults in the last year. The likelihood that you had none has gone down, but the likelihood of an increasing frequency over the course of a year and even over the course of a month has substantially increased in that 4-year period. Think about what the data would show for non-physical assaults. When you assess this in an ICU, this is a very nice point prevalence study, 44 ICUs, more than 600 physicians, a very typical patient population coming from the usual sources. This study plainly demonstrates that as the ICU length of stay increases, so too does the risk of violence. This now perhaps defines a target group for violence interventions. Think about the phenomenon that has evolved of patients that are now discharged home from the ICU because the rest of the hospital is crowded. Length of stay may find a lot of conflict as we confine people to the ICU because there is no floor bed available for them. Contributing factors: confusion, particularly delirium, complexity of medical illness, and in less than an anticipated number, only about a third had some underlying psychiatric illness. This should challenge some preconceptions. 2/3 of the hospitals, you can see them in dark blue, had some preparation for workplace violence, principally driven by a formal document or an incident reporting system, neither of which changed the violent frequency. About 3/4 had some response team, a different kind of rapid response team. But less than half really had any kind of an assessment tool or specifically trained staff. Those things we can change. Intensivists as a group, we underreport. The median is about 50% of us report some kind of workplace violence. The reasons are listed here. It is expected. Nurses have identified this. In particular, the non-physical portion is very expected. Of course, there will be conflict. I'll only report the physical portion because, well, that's visible. Some are worried that if they report, they will then become a target when they were not already one. And leaders in particular have, well, they've expressed some embarrassment perhaps, and they think it may be maladaptive for team dynamics if the leader could not handle and address workplace violence. But most importantly, I think, is that if you report into any of these systems, they're commercially available, they don't use the same taxonomy, and they do not do the very important thing, which is to give you feedback. You have no idea who else has had that problem and what the system has done about it. Therefore, why would you report? Well, if you don't report, this may impact your ability to resolve. This is an anesthesiologist study, principally in the US, but not exclusively so. Most worked in the OR, 10% were intensivists. And 20% of them experienced physical violence principally from the patient's family. 80% of them had non-physical violence exposure from a physician from a different specialty. As a surgeon, I'm sure I have no idea how that could possibly have happened. If you look at the successful resolution of that violence, 40% for the non-physical, but only, or rather 40% for the physical and 30% for the non-physical, it is hard to deal with colleagues. We need a better system. If you look at India, and this was an intensivist survey, most of whom were working in private settings. And as a private setting, they had much more security and video surveillance, and yet 85% of them experienced workplace violence. Most had a very inadequate response, kind of like the anesthesiologists in the US. 1 in 5 had any training at all for workplace violence prevention. What did they want? They wanted communication skills, specific training in that, and in particular, conflict management and conflict management teams. There was a session later in this Congress addressing those issues. Despite having lots of security, they still wanted more, and we'll talk about that in a moment. Let me remind you that not all hospital violence comes from within the hospital. This is the WHO's surveillance system for attacks. You see places that reported over 2018 to 2020. I will call your attention to the Ukraine in the top left. They continue to report. This is last year's data. Look at the number. Nearly 1,200 attacks. 448 injuries, 16 countries and territories, 380 of those attacks impacted personnel, and the major driver of attacks were heavy weapons. But not exclusively, individual weapons featured prominently as well, and those get to be involved in homicides. This is data from Italy. Looking at over a 31-year period, 21 physicians with a broad age range, all different phases of their career, were deliberately killed. They have a rate of 0.67 homicides per year. Now, half of these were in primary care settings or during a house visit. But the rest is relevant for us. The hospital, the streets around the hospital, or your home. Think about that. Think about how easy it is to find where you live. Think about how easy it is to track where you go. This is of concern. For comparison, in the US, for the 5 years prior to this meeting, there were 7 physician homicides. I will call your attention to 2 husband and wife teams. All of the individuals killed in these attacks were killed at work or where they live. Think about that. You need to both prevent it and have a response that works. The Joint Commission accredits US hospitals, and they have some very unsurprising recommendations from a risk analysis, not present in India, in that survey, but also workplace violence prevention programs. This is unsurprising. What have facilities truly done? They've elaborated special teams, a behavioral escalation support team. They are the best. They've increased security. There's a panic button that you can wear as part of your ID tag, and you can call for help any place. There are flags listed in the electronic health record identifying people who are at risk of committing or who have previously committed workplace violence. They're not so good at flow control. Flow control means that there are corridors for patients, visitors, and staff, and other corridors that are only accessible by staff. Access control, your ICU might be keycard locked out to get in. You're often not keycard locked out to get out. Emergency departments are better with that. And of course, those things all work together with workplace violence prevention training. But not all facilities do it well. This is where I work. On the left, you see the old unit. I still work there. Those doors are fixed open. The opening and closing mechanism keeps breaking, so that doesn't work. The new hospital, $1.6 billion, you're looking from the inside of our new unit out to other units. Those doors don't close either for a wide variety of reasons, which means that anyone that comes into the hospital past security has unfettered access to every single space other than the medication room. That we lock. With that kind of an approach, you should not be surprised, and this is now back to that emergency department study, that about 25% of the facilities had no response to workplace violence. The rest of the places that had a response, well, most of them had responses that didn't change safety. The most common durable response was a flag placed in the chart. Even the engagement of law enforcement for an arrest decreased between 2018 and 2022. This seems to be an unpalatable approach to violent perpetrators. What does work? De-escalation training, that's part of conflict management. Disruptive behavior management, including safe physical restraint methods. If you don't know them, these are things you should learn, because you may encounter this. This was a novel solution. A communication board and a mediator was placed in a very busy hospital's emergency department waiting room. Significantly decreased the workplace violence that they experienced. This is translatable to our ICU waiting areas and a role for an ICU survivor to act as that mediator, to interface with families that are waiting. Data on surveillance and monitoring is unclear, but we do need data. And I would advocate that we use data in an augmented intelligence way, thank you, Professor Vincent, for introducing that as well, to use predictive analytics. We have done this and we use data science in a variety of ways around disasters. What we have not done is ask, what is your risk? Which physicians are at risk in my hospital? Is that threat credible? This should be part of our future. But since we're not there and you can't prevent all workplace violence, you must prepare. This is a study that assesses the thing about which people are most concerned, an active shooter. We had this in Philadelphia over the last year. You're looking at anesthesia intensivists and other perioperative staff, and it's a before and after study, 5-point Likert scale. Before is up top, after is down below. Now, most people knew about the run, hide, fight approach, but look at all the other things that they learned from this cognitive and hands-on training session. Where to hide? What was a safe way to leave? How do I communicate, including to get help when I'm doing all of that? And can I locate a self-defense object? This is a start, but it is not all in and of itself sufficient. I submit to you, you need to prepare for the event. You are looking now at the lobby on the left of our trauma hospital. Right next to the gift shop where we have our automatic external defibrillator is a tourniquet and procoagulant gauze. We have the same kind of setup around every single unit, so that if it occurs, you are able and capable of rescuing someone. So if you don't know how to use those, you need to learn those skills. So I'll leave you with these conclusions. This is everyone's problem. There are a wide variety of triggers, but you can find them all in complex care environments. It occurs with high frequency. While the goal is prevention, we also have a duty to have learned competency so that when this occurs, and it will occur, we can provide rescue, whether it's for non-physical or physical violence. Thank you so very much.
Thank you very much all, and we wish you with Haley a very, very nice conference.